So today I want to show you how do I explain my patients that request a treatment for gynecomastia. How do I tell them what do I normally do and what do I don't do. So there is a reason for everything that is done in plastic surgery. So these surgeries are very important to be done in a certain manner. So it is very important to understand that there are some regions, there are some areas where we take, or some areas where we leave the tissue on, or some areas where we augment the tissue, because everything has to be in an order, everything has to be related to other areas. And you know, there isn't a single key that fits all doors. So every patient has a particular situation. So we really need to understand some basic or standard ideas, and then we have to, you know, explain our patients why is the reason for doing that. So I will try to show you how do I do an objective exam or a clinical exam to the chest of for a male. You know, I have some patients that are asking when I do the online or virtual consultations with them, if you want to do liposuction because you think I have some fat near my gland, where do you put the stabbing incisions? Or where do you put the incision from which you will take my gland out? So these are some concerns that my patients address me, and it's very important that if they do not address them, I will tell them and I will explain them, so that they will know every detail and every aspect that is to be done. So everything is in relation to what their tissues are and how their tissues are organized there. So it's very important to really understand these things. So first, when we assess a patient with a gynecomastia, it's very important to highlight the type of gynecomastia that he has. So for example, in this case, this patient has a grade 1 gynecomastia, or let's say not a grade 1, a type 1, which means that he has a puffy nipple syndrome. So this patient has only gland. If you see here, these are the areolas with the nipples, and they are just puffy. So the gland is just underneath the areola, which protrudes the areola. It pushes out the areola. He doesn't have much of fat, maybe something here near the areola, but he is very fit. So he has a pectoral muscle which is very well accentuated and developed. He has this almost perfect synmastia, or cleavage. Let's say cleavage is for ladies, is a term for ladies. He has a lateral pectoral border that is very well developed, has an infrapectoral groove that is also very well developed, has a slight asymmetry between the left nipple and the right nipple. The left nipple sits a little bit higher than the right one. And also, if we try to look here in the upper pole, the pectoral muscle, because he is very fit, looks very nice. So we are always trying, the algorithm is to try to do liposuction if we need to. So in this case, we don't need to do any liposuction, and try to take the gland out. And then we have to see if we have to do some liposculpture. In this case, we don't. Or if we have to augment the superior part of the muscle. So in this case, my idea is to do some liposculpture and take the gland out. Liposculpture would mean that I will do here in the inferior part of the armpit, or the superior part, in the inferior part of the deltopectoral groove. This is the deltopectoral groove. This is the indentation here that separates the deltoid from the pectoral muscle. And here in this indentation, just in the inferior part, just exactly here, I will do a 3 millimeter point stabbing incision, and I will put my cannula, infiltrate the tissue here, and then also do the infiltration in the whole inferior part and do some liposculpture. And by this I mean I will put my cannula and do some movements like this and try to separate. The idea is to try to separate the gland from the rest of the tissues, from the muscle and from the skin. And by this it will be easier to remove the gland, but also this, you know, this ways of trying to deliver the scar, the inside scar between the skin and the pectoral muscle, will obtain and will produce a nicer result, because if we just go in there, take the gland out, we can have a small hole here, and by the liposculpture we are trying to redrape the whole area so that the skin will stick to the muscle in a different way. I mean, here, let's face it, in this case we don't have to do a extensive liposculpture, but just a little bit, so that the skin here will retract and that the patient won't feel that here, for example, everything is perfect and under the areola there is a gap, there is a hole, there is an indentation after the gland was removed. Then we can try to do something like this. We are trying to do an incision from the, let's say, 5 o'clock to 7 o'clock, or from 4 to 8 o'clock. If there is a clock, we can do the incision here like this. Then go in, take the gland out, try to do also some liposculpture from here to try to redrape the skin in a perfect manner, and then put some inside stitches also at the skin, some inconspicuous stitches, subcuticular stitches, and then the scar will be just here at the border between the areola, the hyperpigmented skin of the areola, and the normal skin here. So the scar, after a while, if the patient doesn't have a specific way of pathological scarring, the scar will be, after 1 year, it will be inconspicuous. It won't be seen very easy, just if you go in there and look very, very careful. But even in that case, you won't be able to see it. So in some patients, we are always trying to do the liposculpture to help with the tissues to redrape. So this is the way I will address a patient like this with a puffy nipple syndrome. So here in this semi-profile view, you can see how the nipple protrudes, and it's quite unpleasant for someone who wants to have a perfect chest, because if you wear a tight t-shirt, it's very obvious because the nipples are protruding and they are seenable when you wear something tight. So this is the result after 1 year. We did some liposculpture in the inferior part of the pectoral region by the use of a special cannula. We've taken very small amount of fat. There wasn't much that is to be taken, and afterwards we did the incision here, just from the 3 o'clock to 9 o'clock, or 4 o'clock to 7 o'clock, as we do it on a regular basis. We've taken the gland out. The gland was something like this underneath. And then I checked if everything down there underneath was perfectly distributed. So you can appreciate the result. The scar is inconspicuous. So the lateral pectoral border is very nice. The infrapectoral groove is quite augmented, and the patient was very happy. Here you can see the result in a semi-profile view, and you can appreciate that the areola doesn't protrude anymore. It's not flat or indented either, and it's fixed to the pectoral muscle. And of course, if you want to look here, the scar is almost invisible. You should know that I don't like to do a scar that is linear, you know, perfectly like this, because if you do it perfectly like this, you'll have a difference in the lower pole than in the upper pole. And I strive always to do it like this, because in this way the alignment of the scar, it will look like the scar or the borders of the areola are not perfectly round. And if they're not perfectly round, I mean like perfect, it looks more natural in this way. So you can appreciate the after result when the patient said that, you know, it was just as he wanted to have a result like this. So let's review the result once again. This is the before. This is at 1 year from the front view. This is before in the semi-profile view. You can see the protrusion of the areolas. And this is after 1 year.